Good morning, everyone. In today's session, I will go over the sporozoan parasites, so the parasites that do not move and that are obligate intracellular parasites. I will be discussing the intestinal sporozoans and the blood and tissue sporozoa, mostly Toxoplasma gondii. In this session, you will see that these parasites are usually self-limited infections due to the immune response of the host. However, their features may be very dangerous in immunocompromised patients.
So the learning outcomes of today's session are going to be, first, to recognize the different types of sporozoans with medical importance, to identify their clinical manifestations when they are encountered in humans, and their respective treatment strategies, to understand the impact of sporozoan infections on vulnerable populations, such as, for example, immunocompromised patients, to distinguish the oocysts of different intestinal sporozoa as a diagnostic indication for these infections, to recognize the clinical manifestations and spectrum of diseases that associate with Toxoplasma gondii, especially in immunocompromised individuals and in pregnant women, to identify the therapeutic strategies and diagnostic methods for toxoplasmosis, and to understand the impact of congenital toxoplasmosis on fetal development and the importance of prenatal screening and early detection. The class of Sporozoa represents a class of microorganisms belonging to the phylum Apicomplexa, kingdom Protista. They have no locomotory extensions such as flagellum in case of flagellates, or cilia in case of ciliates, or pseudopods in case of amoeba, and all the species are obligate intracellular parasites. Sporozoa regroup both intestinal and blood and tissue sporozoa. The intestinal sporozoa we are going to discuss in this lecture are Isospora belli, Sarcocystis sui hominis bovihominis, Cryptosporidium parvum, and Cyclospora species. Among the blood and tissue sporozoa, we are going to focus more on Toxoplasma gondii, but we will have to keep in mind that blood and tissue sporozoa include the most deathful species, which are Plasmodia species, in addition to Babesia microti and Sarcocystis lindemani.
The phylum of Apicomplexa regroups a big number of parasites that can be of medical and veterinary importance. Under this phylum, there are two classes, which are the Hematozoa and the Coccidia. Under Hematozoa, we classify the most deadly parasitic infection, which is caused by Plasmodia species and which is causing malaria. Malaria is transmitted to humans after the bite of a mosquito called Anopheles, which upon the blood meal transmits sporozoid stages that will infect first the liver and then the red blood cells in patients. Another hematozoan parasite that can be accidentally transmitted to human is Babesia. Babesia is usually a parasite of cattle. However, it can be accidentally transmitted to human, where it can be found in the blood as pyriform bodies. The focus of this lecture is Coccidia, and under Coccidia, we regroup several species that are called Isospora belli, Sarcocystis, Cryptosporidium parvum, Cyclospora, and Toxoplasma gondii. And all of these parasites can infect humans, and some of them can infect animals as well. The infectious stages of these parasites are called oocysts, and I will be talking about the structure and the content of these oocysts in my coming slides. In my previous lecture, when I introduced protozoan parasites, I mentioned that one way of classifying protozoan is by according to their way of locomotion. I elaborated on flagellates, on ciliates, and on amoebas, which move by pseudopods. Now, I talked also about sporozoan, and I mentioned that these parasites do not have any mean of locomotion. Yet, they have very well developed cytoplasmic or organelle structures that allow them to invade host cells, and all of these are obligate intracellular parasites. Apicomplexan, for example, are characterized by an apical complex which is located, as its name indicates, at the apical side of the stages and regroups a number of organelles including micronemes, rhabdries, and dense granules which play a major role in host cell invasion. It is also worth noting that the life cycle of these parasites is more complex than other intestinal flagellates or ciliates, and this life cycle includes two stages: asexual stages and sexual stages. Asexual stages are hosted by intermediate hosts, and one way of division of these asexual stages is called schizogony. Definitive hosts at their site are also called final hosts, and these lodge the sexual stages of reproduction. These sexual stages happen after a stage that is called gametogony. For example, in malaria, mosquitoes harbor the sexual cycle, whereas humans harbor the asexual cycle. A general characteristic of sporozoa is that the infection by these parasites is normally self-limiting, which means that our immune system can get rid of the infection. That means that this immune response that is mounted against a first infection can be defending us against a new reinfection. Sporozoa infective stages are mostly but not only oocysts, and these oocysts are also the diagnostic stages of these infections. At this level, I would like to tell you about these oocysts, which are sacs that have a very well developed wall that contain two smaller sacs, and these are called the sporocysts. And in each sporocyst, we have the sporozoid stages, where the number according to species can range from 2 to a maximum of 4 sporozoids inside a sporocyst. So this is an oocyst that contain two sporocysts, which are the yellow sacs, and in each sporocyst we can have the infective stages, which are called the sporozoids, and these are the pink representative stages here. And according to different sporozoan parasites, the number can be 2 or 4 sporozoids inside a sporocyst. When we say sporulated, sporulated means infective, means that these sporozoids have already developed in these sporocysts. For some of these parasites, upon excretion of the oocyst, we talk about unsporulated oocyst. That means that the sporoblasts are there, they did not yet develop into sporocysts or sporozoids. As I previously mentioned, coccidia can be divided into intestinal and into blood and tissue. We will start with the intestinal sporozoan parts, and we will be covering mostly Cryptosporidium parvum, Isospora belli, and Cyclospora species. Let's start with the first sporozoan intestinal parasite, Cryptosporidium. The life cycle of Cryptosporidium species is typical of a life cycle of any other coccidium parasite, which means that it involves two phases, a sexual and an asexual stage of life cycle. However, the infection with Cryptosporidium parvum differs in the sense that Cryptosporidium organisms are found just within the brush border of the intestinal epithelium. It's worth noting that both sexual and asexual stages of the life cycle of Cryptosporidium occur in the same host, which is the humans. And these parasites, upon infection, they will attach to the surface of the intestinal cell, and they will replicate by an asexual process that involves schizogony.
The process by which Cryptosporidium species is leading to diarrhea was very well studied, and these studies showed that Cryptosporidium attaches to the epithelial cells of the intestinal cells. It activates the NF-kappa B pathway, which leads to the upregulation of pro-inflammatory cytokines. These cytokines will elicit the prostaglandin-dependent secretion. TNF will stimulate chloride secretion through a prostaglandin mediator, and this is what we can see here, while having TNF-alpha secretion stimulating the prostaglandin production. In addition, TNF is going to stimulate the chloride secretion through a prostaglandin mediator. Interferon gamma, however, is going to induce a leaky dysfunction of the epithelium via its effects on both Na plus H plus ion exchangers and Na plus K plus dependent ATPases. All of these are going to damage the villi and lead to morphologic alterations that we call hyperplasia of the intestinal epithelium. In addition, we observe in case of cryptosporidiosis an impaired glucose-stimulated Na plus absorption. All of these will contribute to the diarrhea. The infection with Cryptosporidium parvum starts when we drink contaminated water. The oocysts that have a thick wall are going to exist in the digestive tract, and the liberated sporozoites are going to adhere to the epithelial cells. So, we will drink contaminated water. The oocyst, which is sporulated, is going to liberate sporozoites. These sporozoites attach to the epithelial border in the small intestine, and this is where we will get the asexual cycle that produces more merozoites that are going to reinfect new cells and lead to diarrhea. Some of these merozoites will undergo the sexual stage by producing male and female gametes that lead to a fertilized zygote. This fertilized zygote is going to become an oocyst, a sporulated oocyst containing 4 naked sporozoites. These sporulated oocysts can lead to autoinfection of other cells or can be excreted to the outside environment by feces, and this is where we observe the diagnostic stage of the parasite.
Cryptosporidium species are distributed worldwide, and infection was reported in addition to humans in a wide variety of animals, including mammals, reptiles, and fish. It is worth noting that waterborne transmission of cryptosporidiosis was well documented as an important route of infection. Cryptosporidia oocysts are resistant to the usual water purification procedures such as chlorination and ozone. It is believed that runoff of local waste and surface water into municipal water supplies is an important source of contamination. Zoonotic spread from animal reservoirs to human, as well as person-to-person spread by means of fecal-oral or oral-anal routes, are also means of infection by this parasite. It was well reported in literature that outbreaks have emerged in daycare centers where fecal-oral transmission is very common. As with other protozoan intestinal infections, exposure to Cryptosporidium organisms may result in asymptomatic carriage. Disease in previously healthy individuals is usually a mild, self-limiting enterocolitis characterized by watery diarrhea without blood. In these immunocompetent patients, a spontaneous remission after an average of 10 days is characteristic. The disease becomes very serious in immunocompromised patients. So in these immunocompromised patients, such as those with AIDS or those with any chemotherapy or prone to bone marrow or organ transplantation, can be characterized by 50 or more stools per day and a tremendous fluid loss that may last for months to years. In some patients with AIDS, disseminated Cryptosporidium infections have been reported. Treatment for cryptosporidiosis differ between non-HIV infected or HIV infected patients. While non-HIV infected patients can be treated with nitazoxanide or cotrimoxazole, HIV infected patients can be treated in addition to these drugs by HAART therapy plus or minus azithromycin. Cryptosporidium may be detected in large numbers in unconcentrated stool specimens obtained from immunocompromised individuals with diarrhea. Remember that these immunocompromised patients may have 50 stools per day and a very severe dehydration. Specimens that are collected may be stained using the modified acid-fast method or also by immunofluorescence assay. And it is very important to note that for Cryptosporidium parvum, what goes out in the stool of an infected patient are directly sporulated oocysts that do not contain a sporocyst because the sporocyst disintegrates upon formation of the sporozoites, and these oocysts contain directly 4 naked sporozoid stages. So this is very characteristic of Cryptosporidium parvum. You will see in the stool of an infected patient oocysts that are directly sporulated and that do not contain sporocysts but contain 4 naked sporozoites.
The second parasite under intestinal sporozoa is Isospora belli. This is a coccidian parasite of the intestinal epithelium, and it undergoes both sexual and asexual reproductions, leading to tissue damage. The end product of gametogenesis is an oocyst, which is the diagnostic stage present in fecal specimens. For example, these are 2 wet mount preparations showing oocysts of Isospora belli. And as you can see, the oocyst contains 2 sacs that are called sporocysts, each of which is containing the 4 sporozoites once it's sporulated. And on this slide, it's an acid-fast stain showing also a sporulated oocyst of Isospora belli, where again we can see the 2 sporocysts, each of which contains 4 sporozoites. The life cycle of Isospora starts when human beings ingest a mature oocyst containing the 2 sporocysts, each of which containing 4 sporozoites. Excistation happens in the digestive tract and leads to the sexual cycle and asexual cycle in the intestinal epithelium. After sexual cycle, oocysts are liberated in feces as unsporulated oocysts that are going to sporulate in the outside environment, which means that the sporocysts are going to develop their 4 sporozoites each in order to become infectious. As for Cryptosporidium, Isospora organisms are distributed worldwide but are unfrequently detected in stool specimens. And this parasite have been also reported with increasing frequency in immunocompromised patients. Infection with this organism follows ingestion of contaminated food or water or oral anal sexual contact. Infected individuals may be asymptomatic carriers or suffer mild to severe gastrointestinal diseases. Disease most commonly mimics giardiasis with a malabsorption syndrome characterized by louse, foul-smelling stools. Chronic diarrhea is associated with weight loss, anorexia, malaise, and fatigue. The treatment of choice is a combination of trimethoprim and sulfamethoxazole. The third microorganism we are going to discuss under intestinal sporozoa is Cyclospora. Cyclospora is a coccidian parasite that is taxonomically related to Isospora, Cryptosporidium, and Toxoplasma. A single species infecting a human has been identified so far and is Cyclospora cayetanensis. Cyclospora organisms are similar to Isospora in that oocysts are excreted unsporulated and require a period of time outside the host for maturation to occur. Upon ingestion, the sporulated oocyst undergoes the excistation process in the lumen of the small intestine, releasing sporozoites. Sporozoites infect cells to form merozoites, and these merozoites will differentiate within the mucosal cells, some of which will lead to the formation of sexual stages. Microgametocytes and macrogametocytes are going to fertilize and produce a zygote. Oocysts are then formed and excreted into the environment as unsporulated oocysts. The pathogenic mechanisms by which Cyclospora species cause clinical illness are unknown. However, the organism usually infects the upper small bowel and causes pronounced histopathological changes. The organism is found within vacuoles in the cytoplasm of jejunal epithelial cells, and its presence is associated with inflammatory changes, villus atrophy, and crypt hyperplasia. The morphologic characteristics of Cyclospora species are similar to those of Isospora species and Cryptosporidium parvum, with few exceptions. The oocysts of Cyclospora species are spherical and are 8 to 10 micrometer in diameter, as opposed to the smaller oocysts of Cryptosporidium parvum that are between 5 and 7 micrometers, and the much larger elliptical oocyst of Isospora species, which can have dimensions between 15 and 25 micrometers. The oocysts of Cyclospora species contain two sporocysts, each of which contain two sporozoites, which in turn contain a membrane-bound nucleus and microneme characteristics of the sporozoan. In contrast, the Cryptosporidium oocyst contains four naked or non-encysted sporozoites, whereas the Isospora oocyst contains two sporocysts, each containing four sporozoites.
Cyclospora species are worldwide distributed, and this parasite can infect a variety of reptiles, birds, and mammals. Although animal to human or person to person transmission has not been yet documented, there is now a compelling evidence that Cyclospora infection is acquired through contaminated water.
The diagnosis of cyclosporiasis is based on the microscopic detection of oocysts in the stool. Oocysts may be detected by light microscopic examination of unstained fecal material, which we call wet mount, where they appear as non-refractile, spherical to oval, slightly wrinkled bodies measuring 8 to 10 micrometer in diameter. They have an internal cluster of membrane-bound globules. In fresh specimens, Cyclospora organisms fluoresce when examined with an ultraviolet fluorescent microscope with a 365 nanometer excitation filter. As for the treatment of Cyclospora, the drug of choice is trimethoprim sulfamethoxazole when available, but if not available, the alternative treatment is ciprofloxacin.
As a summary of the oocyst structure in the three covered intestinal sporozoan parasites Cryptosporidium, Cyclospora, and Isospora, remember that Cryptosporidium parvum oocysts are excreted directly as sporulated, and they contain four sporozoites with no sporocysts. So their sporozoites are naked, and these oocysts are directly sporulated, thus infective. For Cyclospora and Isospora belli, the liberated oocysts in the feces of a contaminated patient are uninfective, unsporulated. This means that they have to span for a period of time in the outside environment until they show their sporulation. While the mature sporulated oocyst of Cyclospora contains two sporocysts with two sporozoites each, that of Isospora belli contains two sporocysts with four sporozoites each. I did not mention Sarcocystis and the life cycle. However, Sarcocystis is different from the three other parasites in that the excreted form of oocyst is directly sporulated, which means infective, and the structure of the oocyst is two sporocysts with four sporozoites each. I would like to emphasize that none of the size of any of oocyst or any parasite that I mentioned over the previous slides or in the coming slides will be asked from you. I do not ask for size of microorganisms or their appropriate infective stages. What is important to me is to know what is the diagnostic stage, what is the infective stage, and the structure of the infective versus transmitted stage.
And here again we show both wet mount or acid-fast stains of different species, where we can see Cryptosporidium where the oocyst contained four naked sporozoites, Cyclospora oocyst and Isospora belli oocyst with the relative sizes of both cysts in case of these species.
So usually when we attend dynamic classes, I usually put some of clicker questions in my slides. Now since we are doing that as VOP, let me go over which of the following is true regarding Cryptosporidium in AIDS patients. The infection is usually self-limiting, persistent and severe infection can occur, mild diarrhea is usually the presenting symptom, is always associated with other parasitic infection. Well, the correct answer is answer B. The second question is, the diagnostic stage of Cryptosporidium parvum is a sporulated oocyst containing 2 sporocysts with 2 sporozoites each, 2 sporocysts with 4 sporozoites each, 4 naked sporocysts, 4 naked sporozoites without a sporocyst. The correct answer is answer D, which is 4 naked sporozoites without a sporocyst. Now that I am done with the 3 representative intestinal sporozoa, I will be discussing one blood and tissue sporozoa, which is Toxoplasma gondii.
Toxoplasma gondii is a typical coccidium parasite related to Plasmodium, Isospora, and other members of the phylum Apicomplexa. And again, I want to dwell on the fact that the most deathful parasite among this category is Plasmodium, of which there are lots of species that are discovered, but 5 are responsible for the human malarial type of infection. Back to Toxoplasma. Toxoplasma is an obligate intracellular parasite, and it is found in a wide variety of animals, including birds and mammals. The essential reservoir or final host for Toxoplasma gondii is the common house cat and other felines. Here you can see a mother parasite in which we can see 2 daughter parasites. And basically, in this type of division, we call it endodiogeny. 2 daughter parasites are getting formed into the mother parasite. Once they finish differentiation, the mother parasite will disappear. Toxoplasma gondii can invade any type of nucleated cells, and this is, for example, macrophages that are infected with Toxoplasma gondii. And as you can see, the parasitophorus vacuole, in which the parasites are undergoing binary fission by endodiogeny and leading to a big number of parasites that will lead to the lysis of the host cell by the end and liberation of tachyzoids that seek for other cells to infect.
The life cycle of Toxoplasma gondii includes 2 phases, a sexual phase that occurs in the intestine of Felida, mostly cats, and an asexual replication phase that occurs in a wide variety of hosts, including mammals, of course humans as part, as well as reptiles, birds, and other warm-blooded animals. Basically, after the sexual cycle happening in the intestine of cats, as an unsporulated oocyst is shed with cat feces to the outside environment. This unsporulated oocyst is not infective until it spends few days in the outside environment. It becomes sporulated, and which means that it will contain 2 sporocysts, each one containing 4 sporozoites. Upon ingestion of these oocysts in contaminated salads, the gastric enzymes will degrade the wall of the cyst and will lead to the liberation of these sporozoites in our body. These will go through the blood and will infect any type of nucleated cell. In these cells, it will transform to the fast replicating form that we call tachyzoid, which is responsible for the acute phase of infection. It's worth noting that these tachyzoids can also cross the blood placental barrier and infect fetus if a pregnant woman is primo-infected during the pregnancy. And according to the semester the infection is occurring, the outcome on the fetus is different, and I will be talking about the clinical manifestations in the coming slides. Now, in immunocompetent patients, the tachyzoids will trigger basically non-dividing cells, mostly the neurons and the skeletal muscle cells, and will transform into cysts containing bradyzoids, which are latent replicating forms or slow replicating forms. And these cysts can persist in our brain and in our skeletal muscles for a lifespan. So these cysts are full of bradyzoids, and these bradyzoids represent the chronic form of infection. As long as we are immunocompetent, we do not have to worry, although now recent reports are saying that there is a very tight association between the presence of these bradyzoid cysts in our brain, and this association happens with several types of neurological disorders, including schizophrenia, including Huntington disease, Alzheimer, and others. There are also new studies that say that the bradyzoid cysts in the brain associate with brain cancer. Other studies are now saying that tachyzoids and bradyzoids associate with several types of cancer. So emerging studies are starting to say that these cysts cannot be asymptomatic. Now, in immunocompromised patients, and this is the danger of the infection by Toxoplasma gondii, the bradyzoid cysts will reactivate, so bradyzoids will transform back into tachyzoids, and they can infect any nucleated cell. And if not treated in immunocompromised patients, reactivation of chronic toxoplasmosis can be life-threatening. The life cycle continues after carnivorism, which means that a cat ingests a contaminated mouse with bradyzoids, and this is where you will have the sexual cycle that starts again. So what is very important to me on this life cycle is to know that cats are definitive hosts, and a way of transmission of toxoplasma is by ingesting these sporulated oocysts in contaminated salads. It's important also for me to know that tachyzoids are the fast replicating forms of the infection that are responsible for the acute phase and that are capable of cross the placental barrier. And it's also important to know that bradyzoids are responsible for the chronic form of infection. These persist in immunocompetent patients in the brain and in the skeletal muscles, so in non-dividing cells, and these form the chronic form of toxoplasmosis in immunocompetent patients. Now, when the immune system goes down, the chronic form of toxoplasmosis will reactivate, so bradyzoids go back to tachyzoids, and this reactivation can be life-threatening if immunocompromised patients. This is one of the most beautiful pictures of pseudocysts. So basically, when we talk about pseudocyst, it's whenever the immune system starts recognizing the tachyzoids. So they start to invade neurons and skeletal muscle cells to evade the immune system, and they start forming the pseudocysts, whereby you can see a mixture of tachyzoids and bradyzoids in the same cyst, until they become bradyzoids full or cysts full of bradyzoids. So again, when we talk about pseudocysts, this is a transition between the acute form of the infection and the chronic one, and this is when the immune system fights against the infection. Always remember that Toxoplasma gondii is a sporozoan, and like all other sporozoans, it is a self-limiting infection, which means that the immune system gets rid of it in immunocompetent patients. And as you saw throughout my lecture, the infection with any of the mentioned, whether Cryptosporidium, Isospora, Cyclospora, or even now Toxoplasma, is becoming. This parasite, as all of the other sporozoan discussed parasites from Cyclospora to Cryptosporidium to Isospora, is ubiquitous. So Toxoplasma gondii is distributed worldwide. I have to dwell your attention that 1/3 of the worldwide population is infected with Toxoplasma gondii. When we say 1/3 of the worldwide population is infected, we mean by that they are seropositive for the infection with this parasite. And I also need to dwell your attention to another point, that acute infection is always accompanied by a chronic infection, which means that a patient who develops the acute infection will for sure have the chronic form in the brain and in the skeletal muscles. Remember that we said that in immunocompetent patients, this infection is mostly asymptomatic. However, it can be symptomatic, and I will be talking about that later on. But this infection becomes life-threatening in immunocompromised individuals. Those include, of course, patients with HIV infection, or patients that undergo immunosuppression for bone marrow transplantation or organ transplantation or others. How can we get infected with this parasite? As I told you, one of the main routes of infection is the ingestion of oocysts that are shed in cat's feces, and this happens usually usually in contaminated salads. But we can also acquire this infection upon ingestion of tissue stages, which are basically the bradyzoid cysts that are in the skeletal muscles. And this is happening by, for example, eating benaye, most importantly, so basically raw or undercooked meat. The transmission can be congenital, and I will elaborate on this in a little bit later. A few cases talked about blood transfusion, and the literature is full of papers that talk about organ transplant transmission, especially people who receive liver and kidney transplant. These are organs that usually can be highly infected with toxoplasma and can be a threat for the immunosuppressed patients they are receiving these transplants. Let's discuss now the clinical symptoms associated with Toxoplasma gondii. Again, this is a self-limiting infection in immunocompetent patients, and most Toxoplasma gondii infections are benign and asymptomatic. I can give you a personal example. I am toxopositive for this parasite, so I have the antibodies against this parasite, and I do not recall when did I get the infection. Some of the patients can experience lymphadenopathy, some of them can develop fever, and the symptoms can be in some immunocompetent patients like those of an infectious mononucleosis. In immunocompetent patients, the antibodies against the parasite can be mounted, and this is usually a self-limiting illness. It may be accompanied by low-grade fever, myalgia, lymphadenopathy, usually cervical. Why cervical? Because, as I told you, the transition from the acute to the chronic form of infection will lead to the formation of brain cysts. So mostly in the brain, they are hiding as life span persistent cysts as a chronic form. Now, also, in addition to the neurotropism of the parasite can access and infect the retina, and this is where it will lead to chorioretinitis. And this chorioretinitis is usually seen in infants, and I will be talking about the phase of appearance of these symptoms later on. And this infection or the chorioretinitis is the result of the infection in the choroid and retina that can be a result of a recent or an old infection, and it can happen in healthy persons and in kids most importantly. These are examples of infected retina with Toxoplasma gondii, and these are pictures taken from patients who experienced chorioretinitis. I would like to dwell to your attention basically that in addition of chorioretinitis that I just mentioned, two spectra of disease can be really severe and associated with toxoplasmosis. These are the neurotoxoplasmosis and the congenital toxoplasmosis. Basically, neurotoxoplasmosis develops when the chronic form of the infection is reactivating back to acute form, and that happens in immunocompetent that gets immunosuppressive drugs, so become immunocompromised for a reason, or for example in immunocompromised patients including AIDS patients. So this neurotoxoplasmosis starts by showing encephalitis symptoms, because this is where the cysts of bradyzoids are reactivating back into tachyzoids. These tachyzoids, remember, they replicate by binary fission, and they replicate in huge numbers that end up by lysing the cells to infect neighboring cells, which may lead to destruction of neurons in the brain, and from there they will disseminate if untreated to reach other organs where they can spread the infection and cause, for example, hepatitis, pneumonitis, and others. And in these patients, treatment of toxoplasmosis is a must, because if you don't treat toxoplasma, it becomes a life-threatening infection. The last spectrum of disease I want to talk about is congenital toxoplasmosis. And as I told you, a pregnant woman that is seropositive for the parasite does not have to worry about her baby, because if she gets infected upon pregnancy, her antibodies can fight against the infection and clear it. However, if the pregnant woman is toxonegative, this is where problems may occur if she gets the infection. So she is not advised to eat any unwashed salads or any raw meat, not to catch the infection, because if it happens during the pregnancy for the first time, the parasite is capable of crossing the blood placental barrier, and it can reach the fetus where it can associate with severe problems. And again, as I previously told you, the spectrum of congenital toxoplasmosis differs according to the time of acquisition of this infection. If this infection is acquired upon the first trimester of pregnancy, it usually leads to abortion. If it happens during the second or the third trimester, the stillbirth may occur. However, the baby will have birth with severe abnormalities that are mostly intracranial calcifications, microcephaly, or hydrocephalus, or others. And more importantly, this baby will have for sure mental retardation. Not to mention that, again, in these babies, the parasite, which has neurotropism and may target the retina, may develop throughout their life chorioretinitis. I just want to recapitulate what happens as outcome in congenital toxoplasmosis. So remember that if the infection happens in the first trimester, it's usually abortion. However, in infants that can be infected after the first trimester, so during second or third, can show different types of diseases. These, or the different types of manifestations. These include epilepsy, encephalitis, microcephaly, which is an abnormal smallness of the head, intracranial calcification, which is the expansion and the overdevelopment of the bone of the skull, hydrocephalus, which is an abnormal expansion of ventricles within the brain because of a higher accumulation of cerebrospinal fluid, psychomotor or mental retardation, chorioretinitis that might evolve into blindness according to the heaviness of the infection, anemia, jaundice, rash, pneumonia, diarrhea, and sometimes hypothermia, which is basically when the temperature of the body falls below 35 degrees, and this might be potentially lethal. Infants may be asymptomatic at birth, but only develop chorioretinitis mostly months to years later. So that usually happens if a pregnant woman gets infected during the last weeks of pregnancy, and the parasite yet successfully crosses the placenta and goes to the retina of the patients. So these infants can be born normal, however they might develop later on chorioretinitis throughout their life. And these children most usually again develop chorioretinitis with or without blindness. They might develop other neurological problems, including mental retardation, seizures, microcephaly, and hearing loss. And here I'm showing you some examples of the outcome of congenital toxoplasmosis. So remember that these outcomes happen whenever a pregnant woman experiences or is infected with Toxoplasma gondii for the first time during her pregnancy. And this pregnant woman might experience problems for the fetus, and these range between hydrocephalus and other symptoms such as intracranial calcifications and others. But this pregnant woman, if she gets pregnant again, she is immune against the parasite, so no danger for the second baby. However, if she gets it during the first trimester, it can cross the blood placental barrier. If first trimester, it is abortion. If second or third, the baby will experience different problems. One of them is hydrocephalus that you can see in this picture. And hydrocephalus means that you have expansion of the cavities in the brain that are more full of cerebrospinal fluid. This is what we call hydrocephalus. Another aspect of congenital toxoplasmosis is basically intracranial calcification that you can see here in this picture, and this happens usually when parts of the brain are eaten by the parasite and there is a compensatory mechanism of overgrowth of bone to replace it. So these are intracranial calcifications that might be seen in the heads of infected fetuses after transmission of the parasite through the placental bag. And to recapitulate a little bit what happens during neurotoxoplasmosis, I would like to emphasize that reactivation of latent toxoplasmosis is basically a special problem in immunocompromised patients. And the symptoms or the presenting symptoms of toxoplasma infection in these immunocompromised patients are mostly neurologic, and they consist with diffuse encephalopathy, meningoencephalitis, or cerebral mass lesions, as I will show you on the coming two slides, where I will show you a CT scan and an MRI of a brain of an HIV positive patients. Remember that if untreated, the parasite can disseminate to other organs, and these patients, if untreated, may experience pneumonitis but also hepatitis among others. The reactivation of cerebral toxoplasmosis has emerged as a major cause of encephalitis in AIDS patients mostly. On this slide, I am trying to show you basically a CT scan of the brain of an HIV infected patient, and here this white spot is basically the cysts of toxoplasma that were reactivated, which means that the bradyzoids transformed back into tachyzoids, which infected or which sliced the neurons, leading to this toxoplasma cerebral. And this is another example of neurotoxoplasmosis that reactivated in another HIV patient, but this time this is an MRI of the brain, and these white foci are also toxoplasma cerebral abscesses that resulted from the reactivation of the chronic form of infection back into acute form of infection. And again, always recall that in these patients, if they are toxopositive, they should be treated, because if reactivation happens and they are not treated, this. Now, how to diagnose Toxoplasma gondii? There are, of course, several ways of diagnostic. The most easy and the most common is the serology testing. So any pregnant woman, when she knows that she is pregnant, or any person who is undergoing bone marrow or organ transplantation, is tested if for the parasite presence by serology. So this is testing for the presence of IgM or IgG in the blood. Whenever IgM is positive, this means that the infection was acquired and this infection was recent. Whenever we find IgGs against the parasite, this is usually an old infection and the person is immune against this infection. So whenever we have a reinfection, those IgGs are capable of getting rid of the new infection. Now, other ways can be used, but they are less common. These can include pathology of tissue, and this happens usually with patients that come with lymphadenopathy and doubt the presence of cancer. These patients are extremely happy when they know that it's not a cancer, but rather it is the parasite present in their lymph nodes. Now, ELISA is another way to do it, and of course we have all the tools to study or to label the parasite by immunofluorescence assay. Now, for the pregnant woman, most commonly we do a PCR on amniotic fluid, and it is very important to track the infection in pregnant women if it is happening for the first time, and it is very important to treat pregnant women, because if not, the outcome on the baby will be severe, as previously discussed. Now, what are the current treatments against toxoplasmosis? They are common treatments that include mostly the antifolates. These include the pyrimethamine and sulfadiazine. Note that these are active against the acute phase of the infection. So far, there is no treatment that is acting on the chronic form of infection, and this is something that I work hard on in my lab, because half of my lab is working on Toxoplasma gondii, and we try to develop treatments and immunomodulatory drugs against the chronic form of the infection using mice and in vitro systems. An alternative of treatment in patients can be also few questions related to this part. So in a case of a patient with psychomotor or mental retardation, chorioretinitis, blindness, anemia, jaundice, rash, pneumonia, and diarrhea, these manifestations appear after infection with Toxoplasma, Cryptosporidium, Cyclospora, or Isospora. Of course, the right answer is Toxoplasma, which is answer A. Humans can be infected with toxoplasma by all means except A. Fecal oral, B. Consumption of undercooked meat, C. Vertical transmission, D. Sexually. So the right answer is answer D, which is sexually, which is the only mode that does not happen during infection with Toxoplasma gondii. Remember that we said that we can acquire the infection by oral infection upon contamination with oocyst. We can get infected if we ingest contaminated undercooked meat with cysts of bradyzoids, and this infection can be happening by vertical transmission between a mother and her fetus upon pregnancy. Toxoplasmosis can be benign and asymptomatic. However, the symptomatic disease may be characterized by all except A. Lymph node swelling, B. chorioretinitis, C. Cerebral abscess and encephalitis in immunocompromised patients, D. Recurrent fever with a periodicity of 24 hours. Of course, the D is the right answer because recurrent fever and periodicity are more common symptoms that show after malaria infection, and the recurrence, of course, is different between the species of Plasmodium. I'm sure Dr. Awar will tell you more about these. However, lymph node swelling, chorioretinitis, and cerebral abscesses can happen if we get infected by toxoplasmosis.
So, to wrap up this section and to see that our learning outcomes fit with the contents, we first recognize different types of sporozoan with medical importance, and in that sense, we discussed Cryptosporidium parvum, Isospora belli, and Cyclospora cayetanensis, with the difference between the diarrhea that is caused by either parasitic infection and the outcome of these three infections on immunocompromised patients. We also discussed Toxoplasma gondii and the spectrum of diseases it causes, and we discussed the symptoms that happen in immunocompromised patients as well as in primo-infected pregnant women. As for the second learning outcome, we identified, of course, the clinical manifestations associated with each of these sporozoan infections in a human and their respective treatment strategies. We discussed the diarrhea with its different features for intestinal sporozoans. We also discussed toxoplasmosis in immunocompromised patients and the symptoms of congenital toxoplasmosis if encountered through the different trimesters of pregnancy. We then talked about the impact of sporozoan infection on vulnerable population as immunocompromised patients, and in that sense we talked about reactivation of toxoplasmosis in HIV patients among other immunocompromised patients. We discussed the chronic diarrhea that can be happening for 50 times in immunocompromised patients. We discussed also Isospora belli, its related steatoria and tissue damage in immunocompromised patients. We then talked about the features of oocyst of different intestinal sporozoan, and we clearly mentioned what is an oocyst, what is a sporocyst, and what is a sporozoid. We mentioned the number of sporozoids in each oocyst and the sporocyst if they exist in terms of Isospora and Cyclospora cayetanensis. As for the clinical manifestations that are associated with toxoplasmosis, we again talked about the reactivation and toxoplasmic encephalitis in HIV patients and in other immunocompromised patients. We mentioned chorioretinitis that can be encountered even after birth, and even if we did not detect toxoplasma in pregnant women. We discussed intracranial calcification, hydrocephalus, mental retardation, among other symptoms when the congenital toxoplasmosis is occurring. We also identified the therapeutic strategies and diagnostic methods for detecting toxoplasmosis, which is mainly happening by serology, among other molecular tools such as immunofluorescence microscopy and PCR. And finally, we discussed the impact of congenital toxoplasmosis on fetal development and the importance of prenatal screening and early detection of the parasite early on during congenital toxoplasmosis in order to avoid the severe outcomes that may be encountered in babies.
So to finish this session, I would like to tell you that I'm a molecular parasitologist. I've been working on Toxoplasma gondii since 2001, so more than 22 years. And basically I have a lab that is ongoing that focuses on molecular parasitology at AUB, in addition to another part of the lab who is focusing on blood malignancies and more recently on solid tumors. In the parasitology axis, since this part of the course cover parasitology, I have two main interests. The first one is on toxoplasmosis, and that is basically by characterizing mostly the host parasite interaction in the chronic phase of the infection. I also have a postdoc and a few master students who are focusing on the effect of immunomodulatory drugs on acute and chronic toxoplasmosis, and we have basically identified in collaboration with Montpellier University uh, imiquimod and analogues that are mostly efficient against the chronic phase of the disease, knowing that this chronic form is currently not treatable by any of the agents clinically. This chronic phase is very important because of its association with neuropathies as well as brain tumors. So I'm focusing on targeting this chronic phase. We published a paper in 2021 on the effect of imiquimod. We are currently working on more potent analogues that are synthesized by chemists at Montpellier University, and we have very promising data about these, but this is pending submission to patent. We also developed a vaccine against murine toxoplasmosis by targeting the moving junction of this parasite, and that was the work of a PhD student who finished her PhD a year ago. And she identified a novel vaccine strategy that is very efficient on the chronic phase of the infection in murine models. And that is basically a collaboration that was with my ex-mentor of my PhD. And the paper is published January 2023 in PNAS journal. Another facet of parasitology I was introduced to is cutaneous leishmaniasis, and that goes back to the Syrian crisis and the amount of refugees who fled the war to Lebanon. And basically, I worked on that project with Dr. Ibrahim Khalifi, who unfortunately left AUB a couple of years ago. And in cutaneous leishmaniasis, we succeeded to isolate two strains from patients from the refugee camp in Bekaa. The two strains are Leishmania tropica and Leishmania major. We published also papers related to immunomodulatory drugs and analogues on this form of the infection. And more recently, I worked with Dr. Antoine Abou Fayyad at the Department of Experimental Pathology, Immunology, and Microbiology, where we gathered our efforts, bacteria and parasites. And Tony basically is extracting natural products from soil bacteria, mostly actinomyces, and isolating the secondary metabolites. My lab tested those secondary metabolites against toxoplasmosis and cutaneous leishmaniasis. We got a published paper also very recently, less than a year ago, by Basil Awada, who is a PhD student at the biomedical program at AUB. And we have ongoing work against toxoplasmosis related to the same topic. With that said, I close the session, and I will be more than happy to receive your emails related to any questions you may have, or also if you need to see me, I am in the DTS building, third floor. Thank you for your attention.